Buenas tardes. My name is Elizabeth Vaquera. I'm a professor here at GW, and I actually do research on health, so I'm very excited to be the moderator this afternoon. I'm not going to spend any time telling you about the biographies of our panelists today, but I'll say the names. We have Luis Falcón, over there. Luis Falcón over here. We have Ann Goldman here and Ricardo Rivera over here. So they will be our panelists today, and I'm going to ask him a few questions. We're going to follow the same process as this morning. As you know, if you have any questions, please put them on a card. And at some point before our final remarks, I'll make sure to collect those and ask a few questions. You know, we are running a little bit late, so I hope you bear with us, and we'll try to finish just about 5 or 6 minutes later than expected. But I won't hold you too long, but I also want to give them the chance to speak and to share all the good work that all three of them are doing regarding health. And before I start, a couple of the panelists had some visuals for you, so I'm going to pass those because they might refer to them as they are answering the questions that I have. So there are two, one from Luis Falcón gave us some, and then Ann Coleman did too. So we are talking about health. We cannot start this conversation without acknowledging all the death, all the suffering, all the mortality and morbidity that came out from Maria and the hurricanes that hit Puerto Rico. So what I would like to start is with a question that I would like all three of you to answer today, which is very briefly telling me a little bit about the work that related to health that you were doing prior to Irma Maria and how that work has shifted because of what happened from the hurricanes. So should we start on the end like this? Do you want to go ahead?
First of all, good afternoon. And you say good afternoon back to me?
Good afternoon.
Luis Falcón, I am the Dean of the College of Fine Arts, Humanities, and Social Sciences at the University of Massachusetts, Lowell. My training is in demography, out of population studies, out of sociology. I have been around for a long time in Massachusetts. And the work that I have been doing over about more than 20 years exclusively on Puerto Ricans and the Puerto Rican population. Back when I was a faculty member in 2002, we submitted a grant to NIH, to the National Institute on Aging, to run a large-scale survey of Puerto Ricans, a very ambitious project. We had done a study of Puerto Ricans, Dominicans, and Central Latin Americans and non-Hispanic whites in Massachusetts, also funded by NIA. And based on those results, we submitted a new grant for a 5-year study. Very ambitious at the time, and fortunately we got it funded as part of 8 centers on population health disparities that we established across the U.S. So we started what became the Boston Puerto Rican Health Study. And since 2005, 2006, which is really when we started fully collecting data. By that time, I was already doing administration and was out of the faculty, so it became a little more complicated. We have been following since a cohort of 1,500 Puerto Ricans in the greater Boston area. And we have done 3 waves of interviews with them. We're now on wave number 4. It's almost a 15-year period by now in terms of funding. NIA has funded 5 years. The National Heart, Lung, and Blood Institute funded the following 5 years. And then NIA is again following the current 5-year project. We have lost about 1/3 of the sample to a number of reasons. You returned to Puerto Rico, moved to Florida. A large number of them, about 200 or so, to death. So at this point, we probably have about 110, 120 journal articles published out of a team of about 20, 25 researchers. And we have essentially a very well-established cohort. There are probably right now 35, 40 investigators working on this data, which is very rich because it has everything from social economic profile to dietary intake to physical measurements, blood samples, saliva, urine, DNA data that we have accumulated over time. And we have looked at a lot of different things, anything from genetic associations with diet and health consequences for this population, where white rice has come out as a fairly problematic thing for some Puerto Ricans. But in general, it has been a very exciting project to be involved with, and I'm happy to talk about it. I think the handout that was passed around, there's a number of indicators from this data set. These are more or less sort of general indicators about things that we found from this study. Particularly, I believe the last page on the handout has the percent from this population that meets the minimum requirements for a number of key indicators of diet and nutrition. So you'll see that this is a very problematic health-wise population. I happened to decide to go to Puerto Rico to visit my parents like 3 days before Maria hit, and ended up seeing Maria in full action down there. And since I have been involved in a number of conversations about the consequences, we actually have a new study that we're rolling out in Puerto Rico that is being led by Josimir Matei, who is an outstanding Puerto Rican scholar at Harvard School of Public Health and a co-investigator in the project. She's the PI and is doing a sister survey to our survey in Massachusetts in Puerto Rico. And we're collecting a cohort of 2,000 Puerto Ricans as we speak to sort of look at some of the challenges related to health, but also follow up on some of the impact of Maria on this particular population and health stuff.
Yeah. We'll follow up on
Yeah,
that
absolutely,
next.
yeah.
So thank you so much. Anne, would you like to tell us about your work?
Okay, good afternoon. I'm in the Department of Epidemiology of the School of Public Health here at GW, the Milken Institute School of Public Health. And my work has been evaluating the costs of prevention programs in mostly community-based programs. I'm also interested in health research on mortality surveillance and disaster management preparedness, and as well as how best large institutions like our schools of public health can promote health in low-income communities, which are usually the hardest hit in whether it's an economic situation or in a disaster. And I was the project coordinator for the study for the ascertainment of excess mortality during Hurricane Maria, or after Hurricane Maria. And I participated in the strategic planning for the study and led the group that studied the death certification process, because we had to figure out what was going on with the death certificates in order to understand why we weren't seeing more hurricane-related deaths. And now, since the hurricane, I've been involved in doing a lot of connecting, and I'm happy to continue to do it, so I wanted to give a shout out between different faculty in the school and people who are working in Puerto Rico. I met a few people today, and we're also, the group that I worked with here is interested in doing follow-on studies with relation to disaster preparedness and mortality. Thank you.
Good afternoon, my name is Ricardo Rivera, and I'm currently the Chief Business Development Officer for Somos Community Care, which is a network of 2,500 community-based independent primary care physicians in New York that decided that enough was enough, so they got together, created a network to change the rules in providing healthcare in New York City. And basically the twist was they wanted to focus on the preventive side and performance, focus in quality metrics, and in the integration with the community at large, specifically with community-based organizations. I have been doing that for 3 years, and prior to that, I was in charge of the Medicaid program in Puerto Rico. I did that for 4 years under Governor Garcia Padilla. And prior to that, I presided a managed care organization in Puerto Rico, and I also served as the Secretary of Economic Development for Governor Acevedo Villar. So I mean, the healthcare system in Puerto Rico basically is Medicaid. It's almost half of the population of the island, and then if you add Medicare, you have another 13%, so 63% of the population depends on government-based aid, and that's in terms of beneficiaries. If you take it in terms of money, Medicare represents between $5 or $6 billion, and then Medicaid represents another $3 billion. So that's $9 billion out of like $11, $12 billion, which is the entire healthcare sector. So basically, before Maria, we had tremendous problems, and we have extreme issues like migration of our healthcare professionals, not only physicians, but nurses, lab technicians, and we were losing them because the opportunities, the economic deprivation, they earn anywhere from 45% to 65% less than their colleagues in the U.S. And that, in addition with the quality of life, access to education, they just migrate. And that created a lot of problems in terms of access to care. And we face waiting times of up to a year to see a specialist in Puerto Rico. So part of my job when I was a Medicaid director was twisting arms in order to make sure that my beneficiaries had access to those specialists. Maria just exacerbated that and just created a condition that the migration that was happening since 2006, when the recession in which we currently are still facing, started. Now, after Maria, it just exacerbated. And is Puerto Ricans looking for access to care, for better education opportunities, better job opportunities. So it is a big challenge, and part of what I'm doing after Maria is how from New York and the work that we are doing in New York, we can then transfer knowledge to Puerto Rico, look at what services and products that we are consuming, things that we can transfer to Puerto Rico, and then create job opportunities in Puerto Rico to provide that service to New York. So those are the type of things that now I'm involved with to try to not only benefit what we are doing in New York, but also benefit the island and their economic engine.
Thank you. I'll continue with you, Ricardo, because from what you said, and I'm going to emphasize it again in case the audience doesn't know, you have extensive experience from what we're hearing both in Puerto Rico and in the diaspora, in New York in particular, right? And you have managed a $3 billion program through the worst Puerto Rican fiscal crisis, and you put the beginning efforts to avoid the first Medicaid cliff in Puerto Rico. So you were talking to us a little bit of like these, like the beneficiaries or people looking for health care in the diaspora, and also trying to figure out how to bring that to Puerto Rico. Can you expand a little bit on that idea, how you are doing it, this migration of people out of the island and needing those health services in the diaspora? So I would like to hear a little bit more about that.
Yeah, I mean, after analyzing this for years, I have come to one conclusion. And even though it's simple, it is complex. Everything behind it is very complex, because the solution, there's not a single bullet solution, because the complex is like a spider web. So you have to attack it in all fronts. But basically, the reasons why the healthcare sector is so deprived in Puerto Rico is, first, because the economic engine on the island just stopped. So as more people need government-based healthcare, then it becomes a high spend for the jurisdiction, and then when Puerto Rico started having fiscal problems, it becomes a recipe for destruction. So, and second, the disparity in treatment in the Medicaid and Medicaid program in Puerto Rico. We are really and this is not because we are Puerto Ricans, even US-based people or citizens, if they move to Puerto Rico, they become second level citizens. Because all the aid that they receive in Puerto Rico, all of a sudden is provided to them under different rules, which are more stringent and constraining. So that disparity creates, also convolutes the problem. So basically, more than advocating and pushing our local congressmen in New York and the communities to push and exert pressure in Congress to stop the disparity and provide parity treatment to Puerto Rico, beyond that, there are other things that I think that we can do. And for example, right now we receive certain services, and we made a list of all the services that we receive, and we said, okay, these type of services can be provided from anywhere. So why don't we provide it from Puerto Rico? Puerto Rico has also, from the IRS standpoint, some protection and some different treatment that provide some tax incentives and tax shelters for companies that are there and provide the services to the mainland. So why don't we do that? And we are stimulating the economy. We are making sure that we create jobs in Puerto Rico so they don't have to come to the U.S. Not because we don't want them in the U.S., it's they don't want to be in the U.S., they want to be in Puerto Rico. So we create opportunities there, and then it's a win-win situation. And in addition to that, transfer knowledge. We are doing a lot of things in value-based payment. When I talk with my colleagues in Puerto Rico, they start asking questions because they don't know, how do you do that? How do you bring that to life? Well, and that transfer of knowledge, sitting down with them, educating them, I always invite them to New York to see what we have done so that they can see, search, and reapply in Puerto Rico. So those are the type of things that I'm doing, and I think that entrepreneurs, company leaders, and people in the U.S. can do also to help the island.
Thank you. Just as a reminder, if you have questions, you can write them on your notes, and I'll take them from you and ask the panelists after this round of questions. And I would like to continue with you. As you mentioned earlier when you introduced yourself, you shared with us that you were the coordinator of the study led here at GW that estimated the excess deaths from Maria. I know probably most of the people in this audience have heard of that study, but I would like to hear about those things and learn lessons and that came about that study that did probably not get that much attention from the media, and particularly for those of you here that are in public health or even the general population that we could benefit from knowing. So can you share some of those with us?
Sure. In the handout, you'll see that the first slide is about the number of excess deaths, the 2,975 deaths that we estimated occurred between September 2017 and February 28, 2018. And the next two graphics are about who was at the highest risk for death. The first one is about people, what socioeconomic level. And the people in the lowest socioeconomic level, there were three that we had to break our data into, were at the highest risk. There was a 45% higher than expected mortality for people living in the poorest municipalities. And the other one talks about older male Puerto Ricans, so we're talking about people 65 and older, and they had a risk of death that was 35% higher than expected through February of 2018. So this is important information, and it's important for public health planning to understand what people die of so that we can plan services. It's also important for public health preparedness planning for disasters, and so that you can try to implement prevention programs in case of disaster and prevention programs in general. And our study showed that the main challenge to the death registration system was that the physicians, who are the sole persons who can certify a death in Puerto Rico, were not, before the hurricane, were not well prepared to do that. They were not trained in death certification. And the ones that we spoke to and other physicians I've spoken to there and here, when you ask them what kind of training they had in death certification, it was usually during their residency with a nurse in a hospital or an attending physician. So there's no standardized training through no fault of their own. I think that's really important to say. And it's also a problem that is a problem across the United States. The people who have the best kind of training for that are forensic physicians, but they don't all get training either, or systematic training, I should say. So if you think about that, not having, this comes down to not having good enough information in a crisis or regularly. So what happens is that everybody dies of system failure, like a heart failure or renal failure. Well, that's really not enough information. You need to understand an underlying condition. Why did that person have renal failure? And what were other ramifications of that as well? So then that leads into the other thing, is that they had no idea about training in disasters. And when the government, the demographic registry in Puerto Rico, which is run by good, it's a good staff, and they do their jobs, they're very proud of their jobs, they noticed there was more than expected mortality. And there were more deaths than normal. And they tried to alert people, CDC gave them guidelines that they have, they tried to alert people, but we're talking about a post-disaster situation that was really prohibitive in terms of communication. So the information didn't get to the physicians. When it did, when the government actually asked physicians to help in death certification, if they were in hospitals that were in remote areas and that sort of thing, there was some resistance because they were not familiar with death certification in disasters. And so the being able to add something like, there was, the death was caused during Maria, was something that, to them, there was no place in the death certificate to do that. There actually is a place for extenuating circumstances, and it's not, there's place for injury and then for extenuating circumstances. But they said they were trained to look at it from a clinical perspective. So this brings us to the fact that many, there is no standard. And then if you want to talk about whether a death is hurricane related or not, it's very hard to make those decisions. So there needs to be a standard both in Puerto Rico and in the United States. And there are some efforts to develop that, but everybody has to agree on it. And because this is a federal system, it makes it harder. But it's also an international problem as well.
Thank you. Luis, as academics, I'm going to ask you a question. Said you know they're academics. Sociologist Elizabeth Aranda and anthropologist Alessandra Rosa have talked about the health effects of the hurricane as something called like personal and cultural trauma, something that the whole community went through. With this in mind, and drawing from the work that you are doing on health inequalities, both of Puerto Rican in Boston and what you were telling us in Puerto Rico as well, where you have gathered so much data about the health of Puerto Ricans. Can you speak about these main findings, as you already hinted at the beginning? And also, I'm interested in hearing about the capacity of community providers to address post-disaster help in terms of need that takes into consideration language and the cultural aspects that are so important for these populations.
Okay. I'll answer what I can remember of the question. Well, first of all, and you have the handout, so you have a lot of indicators. So I won't go into those, but I think that as you look at those numbers, I want you to keep in perspective that Massachusetts has had an Obamacare type equivalent since, way back in late, when Mitt Romney was governor. So the idea that, in our survey, whenever we ask people, do you have health insurance? The answer was always yes, okay? So this is a community that not only has one of the poorest health conditions for Puerto Ricans in the country, but they're in a state where health coverage in general is 100% and is widely available in terms of the number of hospitals in the Boston metro area and so forth. So the question of access becomes critical, the question of language becomes critical to this population, and the question of understanding what, and in particular because we are looking at an aging population. We started with a sample of 45 to 75, something that baffled me because we did, besides doing the quantitative data collection and the pinching and blood pressure measuring and saliva and all that, we did a qualitative survey as part of the study. So we actually went out and interviewed 50 of them intensively for up to 4 hours to try to sort of understand aging for this population, to understand interactions with others, use of language, a sense of community, access, social networks, reasons for migration, future plans, and so forth. But something that really baffled me from looking at the interviews were that some of these people, particularly men, in their early 50s, listing a whole slew of health problems, one after the other and after the other. And then when you ask them to sort of assess their self-rated health, they will tell you, well, I'm not doing too bad given my age. And these were men in their early 50s. So my point, or my take on this was that somehow there was a different conception of what the expectations are as you age, and how should you be aging. So even though in this country in general, people are thinking about 60s as sort of the what used to be the 40s before, or the new 40s, Puerto Ricans have thought about the 50s as being the new 70s for a long, long time. So that's one point. The other one is the idea of social support and social networks. And we have written several papers on this, looking at psychosocial stress, looking at self-rated health. The most recent one, we're looking at food insecurity, which is another big problem in this population, in relationship to social support and sources of social support. And again, clearly it matters, but what is more of concern for this population is that as Puerto Ricans age, and they begin to move to warmer settings, either Puerto Rico or Florida, what happens is that this migration is also selective in the sense of who can actually afford to do this. And what we observe is sort of a breaking down of the social networks of these individuals as those people within their networks that have the better contacts, because perhaps they were slightly better off economically or better educated, start to move away to Florida, start to return to Puerto Rico, and they feel trapped with the winters of New England and not being able to relocate. And suddenly, sources of support, the person that will help them go to the doctor and translate for them, or the person who could, help them get to the supermarket, was just not there. And suddenly their whole system starts to break down. And that's fairly problematic. And in terms of Maria, it has a similar impact, but it's a more accelerated breakdown of social networks. as this large number of people begins to leave the island, relocate, they have no idea what happened to their neighbors, they have no idea who their new neighbors are going to be. In many cases, they move with relatives, but sometimes that is just not enough. My brother and I tried really hard to get my parents to come to the mainland with us. Just no way. There was just no way they were going to leave their home. Why? Because the church is there, the relatives are there, their friends are there. They just could not see themselves rebuilding in their 80s, rebuilding that kind of a social structure. But many people just didn't have an option because they have blue tarps over their homes and they just had to relocate. So in terms of Maria, I worried about the psychic situation of this population where you already have, and you see on the numbers, not only did we find a high percentage of them reporting high symptomatology for depression. And again, this is just a scale. It's not that they are depressed, but that they have symptoms of depression. However, as part of the survey that we did, we actually went into their bathrooms and we looked at all the medication that they were taking and we inventoried the medication. Close to 40% of these people were already prescribed for antidepressants. So even though the percentage look high, the reality is that a number of them are on antidepressants. The problem is that these are the antidepressants that your doctor just throws at you and says, hey, go take this and go home. As some of you may know, depression medication has to be calibrated. It has to be tried. It has to be tested so that until you find something that actually works for you. But that's not happening with this population. They're just being thrown medication at them. Adherence is a problem for this population as well, as they are not, they don't adhere to the medication because they don't understand it, or they feel well one day, so they say, well, I don't need it anymore because I feel well, not realizing that the symptomatology of some of these conditions is far more complicated than, something, well, I feel well today. So the point is, I fear that one of the consequences of Maria is this whole uprooting of social relationships of a population that socioeconomically is fairly limited, relocated, and how do we address a problem of that scale? In Massachusetts, as part of the Center on Population Health that we have, we're currently running, one of the investigators at the center is running an intervention in Lawrence, Massachusetts, which is a population that is about 50-some% Hispanic. In fact, the major is Dominican. And they're running a citywide intervention where they're reaching out to over 2,000 Hispanics and doing healthy aging activities, engagement in social support development programs, diet advice, physical activity, which is another challenge for this population. And they're in the process of moving that program as well to Lowell, Massachusetts. But it takes effort, it takes a lot of money to do these things and to sort of engage the community. Short of sort of targeted interventions at a city, town level, I don't think that there will be a lot of positive results with this population if there isn't some large-scale intervention and a significant amount of funds. I mean, some of these problems can be targeted, but there are so many health complications, diet complications, the uprooting process, poverty, low education. So I'm going to need antidepressants myself pretty soon. So I'm going to stop. But I don't know if I answered your whole question.
Yes, actually, yeah, because I did want to go there, and I would like to offer the opportunity to the other panelists of talking a little bit more about that. I think what you are all touching is on the importance of they do need to receive culturally competent services that understand how to talk to them, particularly even with when we're talking about mental health, the stigma. I was actually surprised of hearing that 40%, but I also was like, yeah, they might take them to get their doctors to shut up, and they not take them, or take it once a week. So you were hinting at actions and community-wide efforts that speak to them, and they make them, kind of understand their own health in different ways. I would like to hear if any of you know of other efforts. You share with a couple with us that you know that they are being successful, that they are working well, or some of them that might be that they might be wider, like some of the things that you have been doing, or people that you're working with in the community. And so Ricardo or Anne, if you want to take it on, I think it would be useful for all of us to know what's working, basically. What do we know that is working out there?
Well, I'm going to tell you two examples. One that we did in Puerto Rico and it worked, and I think that they continue it after my term expired, and that's to target and manage the high utilizers. We, with the help of the National Governors Association, we asked for a grant back in 2013 when I took the helm of the Medicaid program. And we collaborated with them, and then they gave us a lot of education, and we implemented what we call the high utilizer program. And basically it was to pinpoint those Medicaid, well, we researched and analyzed the data, and we end up seeing that 5% of our population really consume almost 40% of the resources. So we said, okay, if we can bend the curve for these people, just empowering them, making sure that they have access to care, and take them out of the ER and take them out of the polypharmacy, because sometimes they have the same medication in different forms, branded by equivalent in every single one, and they didn't know what they were taking because they were going to different specialists, different physicians. And they were looking at the newspaper and then asking, I want you to prescribe me this. So we started with social workers, with nurses, skilled nurses, and we started to impacting those people and establish a health action plan tailored to their situation. And we were able to bend the curve of ER and hospital admissions by 40%. And that created, this all helped a system that was in $200 million deficit to end up in an $83 million surplus. So it was a plethora of things, and this was one of the key ones. Taking those people, not restraining their access to care. On the contrary, we were pushing them, but we were taking them out of the hospital and putting in the hands of the primary care physicians and the community. We established a network with community leaders to help them, because the social portion is very important, as Luis was mentioning. And that helped a lot in Puerto Rico. In New York, what we have been doing is to attack the social determinants of health through the integration of community-based organizations, and that have helped a lot, because there's no one that knows better the community like the community-based organizations. And they tap into our, we gave them the list of the people that are not going to the physicians, that they are not adhering to the medications, and we exchange that information with them, and then they send their people to the community, and they literally drag the people to the physician's office if they have to. But they have the relationship to do it. If I go there, they will say, who the hell are you? So it worked. Now, I'm not going to say that we had a magic wand and all of a sudden today it wasn't, the program was created and then tomorrow was done, because it has taken like 2 years to work out that relationship, because those are two worlds that were in silos and never spoke with each other. So just creating the links to exchange information, just to create the trust so that they know that we are in the same team, and just making sure to try to structure economic equation so that they can be paid by the work that they are doing, and that the premium is the premium. So the government is not going to give you more money. So you are like creating savings and then investing in the community to create the snowball effect, as they call it, and it has worked. So now we are at the stage that instead of calling it community health workers, we are going to push and implement a program that we call neighborhood health workers. It's more broad than only community or only health is about the neighborhood, it's about the pharmacy, it's about the physician's office, it's about the community leader, it's about the community-based organization. And the integration of all those is the only way, at least in my mind, to shift the gears of healthcare into a more preventive versus reactive system.
Well, in our group is interested in understanding the path to mortality from the hurricane. This is something that has never been done anywhere. Understanding and counting excess mortality from disasters is very hard, and then understanding the paths is also hard, but it's very important. Because especially in Puerto Rico, we have a lot of people who have who suffer from chronic disease. So it's important to follow those pathways in order to help develop better prevention programs. And also we're interested in following up on a series of recommendations that we made regarding mortality surveillance and communications after the hurricane. One of the things that did begin to happen was that the Puerto Rico biostatistics system, the Registro Demográfico, has started to train physicians. And they trained over 300 this year. And although I heard people here say the doctors will never go for it, they love the training. And they have a module, they have a training on how to fill out a death certificate in terms of the cause of death, the immediate cause, and then the underlying causes. But there's also a module on disasters, which has still not been developed here in the States. So Puerto Rico is on the cusp of that now. The thing about it is sustainability. They work through the University of Puerto Rico Medical School, and with the collaboration of the Colegio de Médicos y Cirujanos. So it's going well, but the thing is how to keep it going, and for that I know they're in touch with other registries here in the States, and we found out that one in particular, New York City, they send trainers into the hospitals every year with the new crop of residents. And it's a way to get everybody on the same page. And then they have an electronic program, an online course for physicians in the community. The other thing is that Puerto Rico has also gotten money to begin to move to an electronic system, which will help in terms of on-time information, as long as there's electricity. So we went to a preparedness meeting this spring, and everybody talked about cell phones and and media and all of this, and we're looking at each other and saying, what happens if everything fails? So anyway, but they're on in that respect, in the training of physicians, they're on the right track, and they're training physicians in the communities as well. And another recommendation is for them to do, it's also something CDC is trying to do, is to have people trained throughout the United States in what they call medical legal scene investigation. So that you look for certain things when there is a mysterious death, but you also in disasters as well. And these would be first responders and other healthcare and public health personnel.
Thank you. I would like to open it to the audience now. I know that there's a couple of questions, so if you can pass those to me, I'll make sure I ask them. Thank you. Hopefully I can read your handwriting. Oh, those are a lot of questions. You might need to follow up with them afterwards or email them to the, okay. I think there was one that had been waiting for a long time. Hopefully I got you first because I know you've been waiting for a little bit. I think it's for everyone, right? Okay. Thank you for your question. Your name is?
Lina Rivera.
Thank you, Nina. She's asking what role, if any, have faith-based organizations and churches in your initiatives?
I'm going to jump on that one because in New York is. I have to tell you that when I was in charge of the Medicaid program in Puerto Rico, we never leveraged it. We never leveraged the relationship with the faith. And now, when I moved to New York 3 years ago, my organization, the faith-based organizations, they are crucial and they are allies. And I have seen how their role has positively impact the integration and the interaction with the community. So in retrospect, I would have loved to have that experience because I think that in Puerto Rico it would create a lot more value because people are more passionate about faith-based organizations. So I think that, and when I'm talking about community-based organizations, even though we have our mentality of like the typical ones, I'm including the faith-based and any type of community organization that has roots into neighborhoods and communities.
Well, our project carried out alongside the mortality certification registration study, a study on communication of mortality. And so this group went in throughout the island to interview people in community-based groups, faith-based groups, and other community leaders and citizens on how they perceive the communication from the government and how they perceive the environment after Maria. They have gone back to Puerto Rico now with a new set of questions to explore that more deeply, as well as other issues.
The only thing I would add is that, and this comes from a non-religious person, it plays a big role. And I think that what we have found is that the community level, engaging the churches, and it's a big factor, particularly in communities that have been settled for a long time. You have all these different churches. In perhaps a more important role, the Protestant denominations rather than the Catholic Church, which seems to be more common with other immigrant groups, non-Hispanic ones in Massachusetts. But the other piece is on the question of how you cope with problems. We have found that sort of taking a religious perspective on problems is a major piece of how people cope with their individual level problems. And it's not necessarily leading to, at least in what we have looked at, not necessarily leading to better outcomes, but it's leading to them feeling that they're more in control. Or at least that someone is in control of what is happening to them, and that gives a level of serenity to deal with some of these challenges.
Someone wants to know about the state of the Puerto Rican's health workforce. They cite a 2017 report that showed that it was very fragile at the time. So they wanted to know if you had any updates on how we are doing in that regard. I don't know if you want to identify yourself.
Thank you. It was a University of North Carolina report.
Okay. The workforce where? In
Healthcare.
In healthcare in Puerto Rico.
Oh, in Puerto Rico.
Yeah.
That there was an influx of healthcare professionals
Oh,
that
yeah.
left the island
Yeah.
before the
Well,
hurricane.
Ricardo talked about that before,
Yeah.
but I was just in Puerto Rico about 3 weeks ago. And the last time I was there was in Christmas. I was just baffled about how all these clinics are suddenly popping up all over the place. Partly because something that Maria has done is that it took a lot of the working age population that has some resources to relocate out with children. And you'll see it in the decline in the school-going population on the island. So you have all these clinics, sort of building on this Medicare, Medicaid investment in Puerto Rico, sort of popping up all over the place. And actually I was looking at the workforce on the island and how it has changed over the last few years. I think healthcare is right now, I think it's the 3rd or 4th largest sector within the workforce. And it's probably the only one that is actually positive in terms of growth. So the distribution of workers across the island in terms of different occupations, government, of course, is going down, the percent of people employed by the government, which always has been the largest employer for a large number of years. But healthcare is going up.
But I think she's asking a different question. You're talking about healthcare professionals? Because in the healthcare sector, because of Medicaid managed care and Medicare managed care, under the Medicare Advantage program, as he mentioned, that's a huge sector. It essentially addresses 60% of the population. As you know, managed care is heavy on administration. There's a lot of middle management, a lot of customer reps and so forth. So the sector is increasing in that group, but not in the health professional sector where there's been enough
Providers.
Absolutely.
Right.
And it's in the specialties specifically.
Thank you.
Yes.
I would like to continue with the speakers. Is there anything?
No, I mean, just to add to what Luis is
Thank you.
saying, healthcare is very strange in Puerto Rico because you have the Medicare, which is mostly Medicare Advantage. That's the majority of the investment. And that in the past few years, even though we are treated, what we receive per member per month is close to 30% less, 30 to 40% less than the average in the US. But the managed care organizations, they have managed to improve their star rating so that provides them a little bit more funding. And there's a civil war between them, and literally it's dog eat dog. It's like brutal, the competition among them, and there are three big ones, and it's like a battlefield. And they are like investing to try to overcome the other one, but at the expense of the providers. And the providers are being crushed. Like in terms of compensation, their compensation is not growing accordingly to the premium increase in Medicare Advantage, for example. In Medicaid, it's the uncertainty what kills you, because Congress keeps giving you patches. Oh, this will last for another year, and this will last for a year and a half. And then, even though right now the federal government after Maria is paying 100%, there's no Puerto Rican match to the reimbursement process. It's paid 100% by the federal government up to now after Maria. Nevertheless, it ends this year, as a matter of fact, and everyone is like, whoa, I'm not going to raise any rate. I'm not going to pay you more because maybe tomorrow I will not have any money to pay you. So everyone is stagnant because of the uncertainty of what's going to happen, because the cliff is just kicking the can for a few months, and there's not a permanent fix to the situation. And even though there are certain bills in the Senate and in the House, but still, until they are not approved and signed by someone, they do not become law, and there's no permanent fix. It's just kicking the can, and while they are kicking the can, the one that is paying the bigger price are the patients, because they are facing the lack of access to care and the long waits and the prevalences in chronic conditions and lack of money to invest in addressing social determinants of health. But on top of that, the second biggest group is the providers, because that investment, that growth has to come at the expense of someone, of course.
You know, that restriction that we're talking about on services, for some reason, and I didn't hear that, I'm sorry, there's a question, but it's happening too with the Veterans Health Administration in Puerto Rico. They are restricting services, something that I have never seen before.
Wow, that I wasn't aware of, but that's even worse.
Yes, it's worse.
Yeah, the benefits program for veterans is different in Puerto Rico than it is in
Yes.
states.
Also, it's like Medicare and Medicaid.
Yeah, it's,
So I think I have 3 questions here that we can do it as rapid fire. One is, was Hurricane Maria in itself a social determinant of health?
definitely.
For me, yes. Yes and yes.
Disaster recovery.
You got your answer. Second question. Is it plausible that more than 3,000 people died in Puerto Rico as a result of Hurricane Maria? More or less,
Yes,
5%
It's
or less.
plausible, it's plausible. We came up with an estimate that had fairly close confidence intervals, but when we recalculated the Harvard data for the same period, the numbers without the numbers were close, so it's possible. But it's something that it's hard to know.
Someone asked for a lot of statistics. I'm not gonna put my speakers on a pinch to remember, how many percentage of things are here. So I think El Centro has quite a few statistics, and maybe you can talk to them at the end of the panel, so they can refer you to the reports where you can find those numbers. So I'm not expecting you remembering much of the demographic data that I'm very fond of as a sociologist, but I'm not gonna put them. But feel free to come to the speakers after the panel. One last rapid question, because and this opens to the last set of our final remarks when I want to go into this idea of where we go from here, okay, what recommendations you have. So someone in the audience has something that I don't know if you have the answers, but I think it's good for our thinking. It was recently reported that diabetes has tripled in the island. What's next?
Intravenous drug use. IBD, intravenous drug use.
No, diabetes.
So diabetes.
That's what you said.
Diabetes has tripled in the island. What's next?
Next in terms of another disease or?
I don't know who wrote the question. That's all I have.
It's, diabetes is related to a number of factors, but the type 2 dietary intake is a critical part of it. And management of the condition is another critical part of it. I mean, this is not my area of expertise, but some of the folks in my group have looked very closely at factors that are related to nutrition in the Puerto Rican population that impact the condition, and they have a fairly well-defined set of recommendations as to changes that can be introduced within the diet, which are not cost burdening to the individuals, but that could help in the management of the condition. There's no question. Diabetes has exploded within the Puerto Rican population on the mainland, and it's also happening in Puerto Rico. Interestingly, Latinos in general, non-Puerto Ricans, when they come to the mainland, they come with a healthier diet, and that diet over time becomes worse. Puerto Ricans is the other way around. They come with a terrible diet, and over time, as they become a little more comfortable with the language and perhaps the ones that are more educated, their diet somewhat improves relative to the diet that they brought with them. And this is particularly a problem with the whole process of economic development in Puerto Rico, and the way that agriculture was transformed, and the way that the dependence on importing pretty much everything that was consumed on the island took place, and how it impacted sources of what Puerto Ricans eat. And the best example was the lunch that we had from the truck today. Rice, beans, piece of pork, and some onions on top of it, and plantains. There was nothing green on that thing. And what is a Puerto Rican salad on a plate? 2 pieces of lettuce and a piece of tomato that is not even right. So it's part of the challenge here. How do you go around changing something that is sort of cultural, but it's also determined by the way that agriculture, economic development took place on the island? It can be addressed, but it's going to require some fairly large transformation.
And it's not only, it is, many of the chronic conditions in Puerto Rico, it's not only, you cannot attack them only from the health standpoint only. You have to attack it in different fronts. Education. You have to take those kids since they are in kindergarten and keep banging on them. At the same time, you have to create programs, innovative programs, to try to involve the community. There's a social aspect of it too. There's a there's social determinants of health that play a factor. I mean, when you have only $10 to feed yourself for a day, and then McDonald's give you a full meal for $2.50.
Right.
Holy cow! I can take 3 of those and still I have change. If I go to the supermarket and try to buy healthy things, I need $20 and I only have 10. So there's a plethora of things that, and it has to be on the multiple fronts in order to attack the problem. It's not a single bullet, and it's not only in health.
So, it's time for us to wrap up. So, I would like to hear a little bit of like, what do you share with our audience in terms of where do we go from here? What would you recommend in terms of the specific strategies that you have been, that you've seen as being successful, particularly I've been hearing this idea of community, social support. Clearly, we haven't mentioned this word, but resilience is something that I've been hearing throughout your answers. So what take-home messages you would like to share with your audiences regarding what they can do for their communities, that you have learned? This is your chance to.
30 seconds on this.
We have 2 minutes.
It's a challenge. Because, I always try to keep in perspective that the Puerto Rican population on the mainland is not unidimensional. It's not Maria, it's not poverty necessarily. I mean, there are different aspects to the population, so you cannot just describe it in a single sentence as to what it is. So let's keep in perspective that incomes in general for Puerto Ricans in the mainland have gone up over the years. Educational rates have gone up, so there's been significant progress. I think some of the challenges are health related, are definitely socioeconomic, but critically what is killing us with the high rates of cardiovascular disease, diabetes, there are some things that are addressable. My sense is, yes, education, no question about it, but also at the community level interventions that try to create healthy development for children, healthy aging for the older population, physical activity, social networking, engaging in exercise to social support and social networks at the community level. Those things have been shown to work for this population. My partner, who is a nutritional epidemiologist, he always tells me, here's what Puerto Ricans are doing. Beans are the cheapest thing around. But what are they doing? As they look at different points in time and consumption of beans, what's happening? Puerto Ricans are eating beans, but they're eating less beans. They're eating more of the liquid, okay, that they cook with the beans. So that doesn't have the same effect on you. They're still eating white rice. They're now brown rice that can actually be cooked in 20 minutes. You don't have to wait 3 days for it to cook, So, and it actually doesn't taste that much of it. Well, it's different, but it's not quite that different. So, but the point is that there are some things that you can do to modify diet, to educate about diet, to create sort of substitution pieces within the diet, and in terms of exercise to improve the health conditions of the community, but again, it has to be fairly localized because, and it requires the community organizations, the nonprofits, the churches to get engaged into that process.
Well, I heard stories from friends about things that organizations, businesses, and communities did for each other. For their people did for their neighbors during and after the hurricane, and I know my communication colleagues are following that up to look for a way to make it known, because I think it's important for people in Puerto Rico to hear this about what they did, to see it rather than all the bad, and I think it's a model for how people can move forward, and some of the things that you talked about in neighborhoods, people working together, and they can look at these things. I went to a FEMA meeting, I think it was in May of 2018, and it was about what health facilities could do to get money for things that they needed for emergency preparedness. And there were different groups, I think it was ASES, and other people saying, we have this information, and I think there has to be a stronger connection with the Department of Health and the organizations who are working on the ground, so that there can be better feedback, planning, the disaster planning. Somebody commented at a meeting, well, we just do it and she said we just do it to like check off. But disaster planning, part of that is meeting people, working with them, learning how to trust each other, so that when the worst thing happens, we can be there and understand each other. So those are.
Thank you. Yeah, trust is another thing that it sounds like we need to trust who takes care of ourselves or who we can go to. So, Stefan, you have the last word.
Well, I'm going to approach it from the practical standpoint, and I think that all of you can do something, and that something will depend on what you are willing to do and what you have power to do. So the most easiest and basic stuff, portion of it is like you can pick up a phone and you can take a pen and a paper, or have access to an email and email your congressman and tell them stop the disparity with the Puerto Rican Medicaid and Medicare and Veterans Program. And Social Security, whatever disparity, let's stop it, especially in healthcare, because health is health, and everyone in this nation should have access to the best health possible, independently where you live. And that's not that difficult, and if I have been in front of Congress people, and they have told me to the face, why should I give a damn about you Puerto Ricans when you don't even vote for me? You are not a constituent of mine. I owe myself to my constituents. So basically he's telling me, go to hell. And then we educated them, it's going to cost you more, it's going to, if we made an analysis, if someone from Puerto Rico left the island and we paid for their services, at that time $165 per member per month on average. If they went to the mainland, the average of the Medicaid program at that time, that was 3 years ago, the average was $350 PMPM. So even the portion that the state has to put in the Medicaid program was bigger than my entire cost of providing the care. And you know what they say? I don't care, because those are my constituents, and if they come, they will be my constituent, and then if they will vote for me, and that's it. So there's a lot of pressure that should be done, and that doesn't cost you a lot. And if you are in a company that provides services, or you are in a company in which you can influence so that there are programs, educational programs, community-based programs that can be done on the island. Like for example, when the hurricane, I exerted my influence in my organization to create 2 pop-up clinics in Comerío and Naranjito while the disaster was going on. And after the healthcare organizations in those 2 municipalities were strong enough, then we back off, and then they kept running. So those type of things are also important. And if you're an entrepreneur or a company leader, make that list. It's as easy as you need a call center. Like for example, we need a call center to remind our patients of their appointments, very basic stuff. Well, that call center can be done from Puerto Rico, and they all speak English. And in my community, from the 1 million people that these 2,500 physicians take care of, 75% are Hispanic, and Spanish is their first language. So they all speak Spanish. So those are the type of things that we can do. I'm not asking a pharaonic endeavor, just as a piece of sand, just one grain of sand, it can do a lot. And if you have influence in your relatives and stuff like that, you can influence the adherence to medication, to physicians' recommendations, to diet, to that stuff. There are like 20 people or 30 people here. 3 that you impact, all of a sudden we have 90. 3 more, 270. And all of a sudden we can reach out the 3.4 million people in Puerto Rico. Because in the end, there are 3.4 million, the last time I saw, because migration is killing the island, 3.4 million on the island, but in the United States there were more than 5.2 million Puerto Ricans.
Well, gracias. Thank you.